Hello and welcome to the show, Meet the Masters. Today we have a master surgeon with us, Dr. Mohamed Ismail. Welcome, doctor. You are one of the pioneers in laparoscopic surgery. Can you explain us how you got specialized in this and why?
I will just try to explain it with an example. If you have got a room without any windows or the doors and you want to take something from that room out, then the two ways you can do. Either you can break the wall and then go inside and take the room, or you can make a small a hole inside, and with some instruments you can take that thing out. It is just like that. The abdomen is just like a room without any doors or any windows. So previously we have to cut open the abdomen. So for that, the abdominal wall has got many layers, from the skin and underneath the fat layer, then the fascia, then 3 layers of the muscle layers, and then the peritoneum. So all these layers you have to cut, and then only you can enter into the abdomen to do some surgery. This will, whenever you are cutting the tissues, then the nerve endings are getting cut, and then you will get the pain. And not only that, once you cut it, then you have to suture it again. So to get the normal tensile strength of that previous, the uncut, the abdominal wall, minimum it will take 3 months, 90 days. That's why after the surgery, the patient has to take rest for minimum 3 months. So now the advent of the instrumentation, that is mainly the video endoscopic instruments. That means we have got now there are a lot of the web cameras, or everything is there, but almost 20-25 years back, that is way back in 1990, they have invented the cameras and telescopes which you can put into the abdomen through a small hole. That is a port which won't cut anything. If you make a 0.5 centimeter or 1 centimeter incision in the skin, then this port can be put through the muscle fibers without cutting the tissues, what I told earlier. So there won't be any pain, and you can see the organs inside the abdomen with much illumination and with much magnification in the screen. And again, with another 0.5 centimeter or 3 millimeter incisions, you are putting 3 or 4 other ports, and through that there are instruments available through which you can do the surgery. But the difference is that the open surgery, you are looking into the abdomen and then doing it. In laparoscopic surgery, you are seeing the images in the screen, and then you are doing something here with seeing there. So it needs some a hand-eye coordination. But the advantage is tremendous, because the patient doesn't have any wound in the abdomen, so there's no pain, there's no bleeding, because the magnification is so high, the illumination is 300 watts light. So it is just like that you are doing some surgery under a microscope. You are doing the laparoscopic surgery. So the patient is back to work early, because they don't have any abdominal wound, so that you have to take rest. Initially the laparoscopic surgery, when I started almost 25 years back in 1992, actually the innovation in the laparoscopic surgery happened in France in 1990. In 1992 it has come to India, and I had the opportunity to start the laparoscopic surgery in Maulana Hospital. That is, you remember that time it is only a Taluk headquarters. We could start that laparoscopic surgery in 1993 itself. That is just because the patient's comfort, the refinement in the surgery, because you are seeing the organs very large, and no bleeding, no pain. So that is actually fascinated me, because you could when the laparoscopic surgery started, actually there are only 2 surgeries. That is the laparoscopic gallbladder, that is diseased gallbladder you can take, or the appendix. But after that, many surgeries we could do through the laparoscope. This is when I went for my training, my teacher told me that your imagination is the limit of laparoscopic surgery. Actually, that is very true, because now almost everything you can do through laparoscope without opening the abdomen.
Doctor, you got trained from well-known surgeons abroad. Can you share us your training experiences?
Yeah, the laparoscopic surgery actually the pioneers in India. In 1992, it is Woodwardia who has done the laparoscopic cholecystectomy in morning and evening. The same day, Dr. Agarwal, J.B. Agarwal in Mumbai again did his lap cholecystectomy. I had the opportunity to work under Dr. J.B. Agarwal. I went with him, and that time also, this is again for them also it is only the learning period. So I was with him for almost 13 days, and I could see the many laparoscopic surgeries done by him. So the basic knowledge of the laparoscopic surgery I got from Dr. J.B. Agarwal. And after that I had gone many places because those times how this laparoscopic surgery has spread by workshops and the conferences. We used to have a lot of conferences where the renowned experienced surgeon do the surgery, and that live telecast of these surgeries will happen in the another hall. The theater they will do surgery, and another hall in the same building or in the another building we will sit and we will watch the surgeries they are doing, and we can communicate with them. Orally we can communicate, we can ask the questions, and I believe I must have attended more than 100 or 150 workshops by various surgeons from abroad and from India, and that's how I learned surgery. And definitely after coming here we started because those time I was a general surgeon. I am a general surgeon, and we used to get lot of general surgery cases like the appendix from the pediatric age to the adult age. I used to attend a lot of workshops and conferences where there are a lot of foreign faculties comes and operate, and the live surgeries we could see and we could ask questions and interact with them. So that was the main actually my teaching background. Of course, the basics I got from Dr. J.B. Agarwal was the base. And again, the another advantage for me that we used to get lot of, as I am a general surgeon, we used to get lot of cases in the Maulana hospital. So we could try almost all the cases through laparoscope safely. And if I talked about the foreign faculties, I think almost all the foreign faculties visited India for teaching us the laparoscopic surgery, especially in Coimbatore, the hospital run by Dr. Palnimelu. He is another pioneer laparoscopic surgeon in India, and Dr. Pradeep Chaubey in Delhi. And we formed a association, that is Indian Association for Gastrointestinal Endosurgeons. So from the first conference in Delhi and the second conference in Mumbai, now we have completed almost 19 conferences, and all these conferences I used to, I'm an active participant and learned a lot of techniques.
You have started the first bariatric surgery center in Kerala. Can you explain us the process of bariatric surgery?
Yeah, that is again, when we started the laparoscopic surgery, we used to call it is the basic laparoscopic surgeries, and there are advanced laparoscopic surgeries. Basic laparoscopic surgery, you mean the lap chole, lap appendix, like the small cyst removal and all these things. And then the advanced surgeries, like you can do the cancer surgeries through laparoscope. You can remove the esophagus, you can remove the stomach, the colon, the diseased part. That comes under the advanced laparoscopic surgery. So I was having the opportunity because I was doing the onco surgery through laparoscope first time in Kerala, and I presented my paper in Trichur, one of the our association's conference, and got the best paper award. I could do many the first in India, like you can tell another disease was that time the perforated ulcer perforation in the stomach. If the ulcer got perforated, then the patient comes with peritonitis, that is the infection. So I again tried, because those patients are very sick patients, like most of the patients are smokers, so they will have a bad lung, So when you open the abdomen, the postoperative period is really astounding, because they will cough postoperatively, they will have pain. So there is postoperative pneumonia and all these things. So those type of the patients, I tried laparoscopically closure of this perforation and the clearing of the washing of the abdomen. This is also the first paper I presented because here we used to get a lot of perforated ulcers those time in 1993, because this area, a Muslim populated area, a lot of our patients are smokers, and they used to get this ulcers and with perforation. So that is another surgery we did. And again, the pediatric surgery I told earlier, the pediatrics again, that is again the first pediatric laparoscopic paper. Almost 136 pediatric patients I did and presented in 1999 in our conference. So that also because that the advantage is that I used to get a lot of pediatric patients, and I tried the appendix, intussusception, the bands and all these things, through laparoscope I could do the surgery. And similarly the bariatric surgery, because that is popularized all over the world by 1995. Actually the bariatric surgery started through laparoscope, and in India 2004 or 5 it has just started. So I had the opportunity to learn this bariatric surgery from Bern in Switzerland, and 4 centers I had the opportunity to visit for a week, and I learned the technique, because the bariatric surgery itself is different, because the patient is different than the normal patients, because these patients, morbidly obese patients, they have got all the systems are compromised. The lungs, their heart, all the systems are compromised because of the weight. So they have to be treated very carefully. So even though I had the training in 2003 in Switzerland, I took again another 5 years to start my cases. First case in 2006 in Kerala, in Maulana Hospital, because I attended many conferences again. Just make sure that, because safety, whatever you do fresh, the safety of the patient is the most important thing.
Raising obesity is a global phenomenon. Do you recommend bariatric surgery as a panacea for obesity?
You're absolutely right, because obesity is a major health problem globally. It has got many complications. The obesity itself we have classified into many stages, depends on the BMI. The two things we are taking into account, whether we have to tell whether the patient is obese or not. I mean, for any patient, according to the height, there is a definite weight is there. That is called the body mass index. This is calculated by height in meter square divided by kilogram in weight in kilogram. That is the our BMI, body mass index. So normal body mass index is from 18 to 23, and from 23 to 30 it is called just a chubby, because you can in that area, if you comes, the obesity can be treated by changing your lifestyle, the exercise, and even the medicines. If the BMI is more than 30 or 32, then because of the obesity, the direct other diseases will come, like the diabetes mellitus, hypertension, atherosclerosis, the arthritis, the varicose vein, and the list of these diseases which is as a result of the direct obesity is, I mean, every day it is increasing. Even the cancers, the CA breast and the carcinoma of the cervix, this is all as a result of it has got a direct, because the obese patients, these diseases comes in a higher percentage. So once the BMI is more than 30, there are specific guidelines from the IFSO, that is the International Federation of Surgery for Obesity, or we have got a different, because our stature is little different than the Western population. So the Asia Pacific Bariatric Surgery Society, so they have got a different guidelines. The BMI is a little less, the 2 BMI less, that is the indicated for the surgery. So BMI is one marker or one thing we are going to take it as a whether this patient is needs surgery or not. And the other thing is our waist circumference. Especially in Indians, the obesity is central obesity, the extra fat which is going to deposit in around our waist. So if in males, if the waist circumference is more than 90, or if the females, if the waist circumference is more than 80, even if the BMI is 30, the patient is a candidate for bariatric surgery. So once, if that BMI is more than these guidelines, the bariatric surgery is only the permanent solution for treating these patients. To resolve his, not only that will bring down his weight, but it will resolve all the comorbidities like the diabetes, hypertension, and cardiac disease. All these things will come down.
Being a surgeon who has done more than 1000 bariatric surgeries, what are the risks of bariatric surgery?
Yeah, this is as I told earlier, these patients are different patients. Like they are compromised, the heart is compromised, the lung is compromised, all the vital organs are compromised, these patients. So you need a special care on these patients, and these patients won't tolerate any complications. Like even a stitch abscess, they may go into problem. So you have to investigate these patients very thoroughly. You have to take all the cares to prevent the complications, any type of the complications. Like even a small fever postoperatively is really raise the heart rate of the surgeon, because that itself can, any type of the small infection can kill these patients. So you need a special care, and you need special facilities. Even these patients are morbidly obese patients are 150, 160, 180, 200 patients. Even to transport these patients, you need a special table. To operate, it needs a special table. To do the surgery, it needs a special instruments. So it is not a simple laparoscopic surgery or any other laparoscopic surgery doing in a normal person. So you need training of the surgeon, you need extra facilities in the center, you need the know-how if there is some complication. Because it is surgery, you cannot tell that 100% it is a complication. There may be a complications. So when that complications comes, you will be able to recognize the complications in time, and you should be able to tackle the complications. So that is the importance of the bariatric surgery. That's why it cannot be done by any other laparoscopic surgeon or any other center. It needs a special care, it needs a special facilities to do the surgery. Otherwise, it is that's what I told. I took almost, even though I was doing all the advanced laparoscopic surgeries for many years, even after my basic training in the bariatric surgery, I took almost 5 years to start the first bariatric surgery in 2006. And after that, in last 8 years, Alhamdulillah, I could do almost 1000 cases without any much problem.
Doctor, you are specializing in endoscopic hernia repair as well. What are the pros and cons of endoscopic hernia repair when compared to the traditional one?
The endoscopic hernia repair is actually, it is a passion for me, because the hernia, as you know, it is a defect in our anterior abdominal wall, and through which the bowels are coming. So it is a closure of that defect. So when we do open surgery, as I told earlier, we have to go through many layers of the anterior abdominal wall to reach that defect, like the skin, the fat, the 3 layers of the muscles, and then we are seeing that defect, and then we are suturing that defect with mesh or the sutures. So that all the cutting and the suturing that has got that will result in some amount of the pain. In endoscopic hernia, what we are doing is, we are just, because it is the anterior abdominal defect, and through which the peritoneum or the layer which covers the bowel is coming out. So what we are going to do is, through the endoscopic hernia repair, We are going the plane between the abdominal wall and the peritoneum. So there is a space, potential space. So through just 1 centimeter incision, we are going into that space and then just putting the gas inside and inflating that area, and then just retracting the protruded bowel in, and we are putting a mesh here. So in that endoscopy hernia, in fact, there is no cutting, there is no suturing, there is no invasion into the tissues. It is just a separation of two potential spaces in the anti-abdominal wall and keeping the mesh inside and coming out. So definitely there is the patient's comfort is much better in endoscopy hernia repair. Actually, I started this endoscopy hernia repair way back in 1994 when I started the laparoscopic surgery. That time the hernia repair was not started. There is no definitions of this repair. Then the first hernia repair I took almost 3 hours. For the open hernia repair it will take only 20 minutes, but in the first initial 33 patients, because nobody was there to teach what is the steps of the endoscopic repair. Many surgeons were trying many ways to do it. Trans-abdominal pre-peritoneal mesh repair, trans-extraperitoneal mesh repair, and different types of the mesh repairs were there. So the first 33 cases I did, and 3 cases got recurred. That means almost 10% recurrence in that series. So I stopped doing the endoscopy hernia repair that time. And again, I went to many workshops and many conferences. Then one surgeon, Dalak, he's a French surgeon who was doing the trans-extraperitoneal mesh repair, TEP it is called. Now it is very popularized. Then I got the idea, or then I started doing the TEP. So way back in 1996, I started doing the TEP repair, and then I could standardize the techniques like the step 1, 2, 3, 4, 5, 6 like that. And there are a lot of surgeons came here my place, and I could teach many surgeons. And now we closed almost 8,000 hernia repairs in last almost 20 years, and it is absolutely a nice surgery which gives a lot of benefit to the patient.
Breast cancer is another emerging health issue. What are the process of breast reconstruction and how far it is successful?
We know that it is when we are a woman is diagnosed to have a breast cancer. We have got many methods now for the early breast cancer, that is the first and second stage, the breast conservation surgery, all these things are there. But in India, our population, most of these patients comes in the third stage or fourth stage, which needs a mastectomy, a breast removal. And those type of the patients, if the patient is between the 40 and 50 years of age, that time when they lose a breast, that has got a lot of psychological trauma to that patient. So in that scenario, the breast reconstruction has come out. So from the anti-abdominal wall in the lower, because usually these ladies, they will have some amount of the fat in the lower abdomen. So with the help of a muscle there, this fat and the skin can be taken subcutaneously through the under the skin. We can bring it here and we can form the new breast. And even the areola can be reconstructed with the vaginal skin, because that skin has got that wrinkled effect. Or you can take the flap from the posterior wall of the thorax, that is latissimus dorsi flap. I usually take this one because this is more stable and it is more cosmetic. So that gives a lot of psychological advantage to the patient. They've got, I mean, after some time, after healing all these things, even the sexual satisfaction itself will be more with this type of the patients having a breast reconstructed breast.
Is it a success in all cases?
Yeah, it's very successful because only I mean, we have to select all these cases. Which patient has to be go for a reconstruction? If it is a stage 4 and there are a lot of secondaries in the axilla, then these type of the patients has to go for a radiation postoperatively. And those patients who have to go for a radiation, we may not do a reconstruction because that radiation itself may cause damage to the reconstruction. So this patient has to be selected for the reconstruction.
Doctor, it seems that you are so keen in trying new technologies in surgery. How do you update with the new technologies of healthcare industry?
Yeah, I told you, basically I'm a general surgeon. So in my department, I mean, from a incision and drainage of a pus to the advanced diabetes surgery, because now we have got the surgery to cure the diabetes. It is the because whenever there is a new technology comes, I will see that whether this technology has got any benefit to the patient. Whether if the technology gives benefit to the patient, then I try to learn the technique. I will go for the conferences, I will read it from the net, and I will contact because one of the advantage I got, many surgeries I learned from the inventors. If you take the surgery for the piles, it is a very common problem for the population, but the anal canal, the piles means the hemorrhoids, that is one disease which has got the maximum pain to the patient, because the anal canal or the perianal area is the most sensitive area of our body, one of the most sensitive area of our body. So any wound or any cut in that area will cause severe pain. So where I trained in Pushpagiri, Tiruvalla, with Dr. Y.P. Abraham, a great surgeon. So we used to have a lot of hemorrhoidectomies. I found I used to watch Dr. Abraham tries many techniques to just alleviate the pain after the pile surgery. Because there is a wound, almost 2-3 weeks, this patient will have pain. So another innovation has come in during 2003-4 is by Dr. Antonio Longo from Vienna. He has developed a instrument through which you can take off the whole pile masses without any wound in the anal canal. So that has really fascinated me. Again, I had the opportunity to go there and got the training from him. And again, I can go to another surgeon who was doing regularly is the Sochen from Singapore General Hospital. I had the opportunity to work with him. So from the inventors, when we learned, that the refinement of the surgery is much higher. That is one advantage I've got during my career, that I could learn many techniques from the inventors.
The success story of Maulana Hospital is closely related with your career. Can you share the experience of this togetherness?
Actually, I just remember almost 25 years back, that is, Maulana Hospital started in August 31st, 1990. And I came to Perindalmanna from Kottayam. I never thought I will come to Malappuram, because whenever the post-graduation period, when a advertisement come from Malappuram, I don't usually watch it, because the Malappuram, I thought it is a far off place. But I mean, this is all destiny, Allah brought me here. And the surgeries, when I started in 1990, the many things we could work with the management, because this is all the quality and the goodness of the management, because they have got me the free hand to develop the department. Even the laparoscopics at that time, it cost almost 14 lakhs rupees. And Mr. Rashid, even he didn't ask me to get that instrument here, because those time in Kerala, because as I told earlier, the laparoscopic cholecystectomy is one surgery which can be done through the laparoscopic machine, because that is the basic laparoscopic surgery which we can do. But those times in Kerala, laparoscopic gallbladder disease is not that common. It is the ulcer or the appendicitis which was more common. So the number of the disease, if you take, it may not be viable with buying that instrument with the 14 lakhs and investing a lot of money. But Mr. Rashid just brought that instrument, and then I had to go for the training. But that changed the whole scenario, as the advent of the laparoscopic surgery has ignited an explosive period of growth, not only in the gastrointestinal surgery, it is in all the other fields of surgery. Just like that, when we started the laparoscopic surgery in Maulana Hospital, the scenario has changed, because everybody thinks that, the people thinks that is something new and some definitely has got advantage. So the other surgeries also has increased, not only the gastrointestinal surgery, because laparoscopic surgery, you know, the surgery we are doing in the abdomen, but the other surgeries also, like the thyroid, the breast, the varicose vein, everything has increased as I started the laparoscopic surgery in Maulana Hospital. So that has really changed our career.
As a medical practitioner, what are the challenges you face?
The main problem of which in my concept, the cost of the surgery. The cost of that is what I usually tell every conferences, every my juniors. We know that all these instruments which is importing from the from other countries, so it is very costly. I was just thinking, I mean, we could send our own rocket to even to Mars or to other satellites. All these things are indigenously made, but never the medical instrument, nobody is trying to make it indigenously. That's why all the cost of these instruments, that itself will increase the cost of the, but the other way I used to tell, in India, mainly especially the surgery cost, I believe it is all depends on the surgeon's fees. In all the, I believe it is like that. I don't know about the other hospitals, but most of the hospitals, the fees, the total cost of the surgery depends on the surgeon's fees, because the percentage of that surgeon's fees, they will put it as OT charges, they will put it as the anesthetist charges, and of course the medicine you cannot help. That's why when I started the endoscopic hernia and the treatment for the minimal invasive procedure for the piles, I tried to reduce my charge, so that let the charge, the whole charge, let it come down, because I just want to give, because this gives a good to the patient, and let more people get the advantage of this innovative surgery. Otherwise, if you put it as the cost is high, of course you will get the patients and you can charge it nicely, but the number of the people who is going to get the advantage of this particular surgery is going to be reduced. And not only that, I believe the excellence comes out of what you repeatedly do, isn't it? So when you have got more patients to do the surgery, you are going to excel in it. That's why when I did my first endoscopy hernia, it took 3 hours. Now with 15 or 20 minutes I can finish endoscopic bilateral hernia. That is because I have done more and more cases. The more and more cases I could do, because I could do it in an affordable cost. That is a big thing. And the challenge, if you tell, if you ask me, it is the knowledge you acquire, because especially the younger generation, I found they don't very keen on learning the thing, because from my experience, I have traveled a lot. I sacrifice my many things, my family life, my money, my time, my health, everything to learn these techniques. But now, nobody wants to learn the technique and do it. Again, in bariatric surgery, I used to tell that many young surgeons just seeing the video and start doing the case. It is unsafe for the patient. So they have to spend in learning by sacrificing many things, and then only you can acquire the thing. So that is the one message that I want to give to the younger generation, younger surgeons actually.
What are your future plans, doctor?
Now there are many things new in the surgical field, like the robotic surgery. That is another new area of the surgical field. But I was not yet convinced about the robotic surgery, how much it is giving benefits to the patient. But as a person, I am very much interested in the diabetes surgery, a surgery which has developed over past few years to cure the diabetes, because diabetes is another disease. It is a silent killer. It will affect, just like the cancer, all the cells in our body, and it affects, I mean, as you know, the kidney, the eyes, the nerves, everything it is. And even the WHO has declared that 77.6% of the diabetic patients are dying of heart disease. That means there is a correlation between almost all the diabetic, 2/3 of the diabetic patients are getting the heart disease. So with the medical treatment at present, we are just controlling the blood sugar. We are not curing, or we cannot, to some extent only we can prevent the end organ failures of the diabetes. But the surgery which we have now, it is getting developed, can cure the diabetes. I had the opportunity with the ICMR sanction, I could do a research work, because if the BMI is more than 30, almost 100% the patient can be, the diabetes can be cured with the surgery. Again, the same surgery we can do in a low BMI patient, that is a normal weight patients. I already, we crossed almost 150 patients we have done in a normal weight patients, different surgeries, because that is there is some gray area, which surgery needs which patient and which of the selection of the patient. So this is slowly coming out, but definitely the bariatric surgery, all the metabolic surgery it is called, metabolic surgery has got a role, and in coming years definitely that will change the treatment of the diabetes mellitus and the complications of that.
Thank you very much for your time, doctor.
Thank you. Thank you very much.